Welcome back to Get Moving TV. I'm here with Dr. Hornstein. Dr. Hornstein has been on our show before talking about something that's a difficult time for all of us, and that is towards the end of life. What really is the quality of life that we have, and how can we help people to understand that and work our way through it so it remains a quality throughout the course of our lives. Dr. Hornstein, welcome back.
Dr. Landon, a pleasure to be back.
Well, one of the things that I don't think we got a chance to talk to about before is just kind of the history of how we get to these directives there. Certainly some of my patients are do not resuscitate, and when we have a child who, if we try and resuscitate them one more time, it's really just a life of misery and pain. We want to do what's medically appropriate care. I know in the hospital I'll see stacks and stacks of advanced directives. So if you could tell us a little bit about the history of the do not resuscitate and advanced directives and where things are going now.
Oh, I'd be happy to, Dr. Landon, and thank you for having me back. You know, if we looked back historically about 100 years, a child born in 1900 would statistically live about 50 years. And usually at about age 50, maybe 49, 51, that individual would get an acute illness, usually a pneumonia or a bad infection. And because at that time there was very little use of antibiotics, or they may not have been developed, the person would die, and they die pretty quickly from that infection. Now you fast forward 100 years, from 1900 to the year 2000, and a baby born in the year 2000, if it's a boy, will probably live about 78 to 79 years. Almost 30 years more than just 100 years ago. And if it's a girl, probably into her early 80s. So all of a sudden, just as the way that healthcare and public health and medicine has rapidly progressed in the last 100 years, we have seen an increase of life going from about 50 to into the 80s. So what we have seen is people are living longer. But in addition, in the old days, in the days of grandmother and great-grandmother, they got sick with an infection and typically died very quickly. Now, however, what we're seeing is people living for 10, 20, 30 years with multiple chronic illnesses, things like heart disease, lung disease, kidney disease, different gastrointestinal diseases, and cancer. So that people now, when they get into their 60s, 70s, and 80s, frequently have had 1, 2, sometimes 3 diseases that they've been managing all along as they then get into the later part of their lives. And so about the 1960s, there was this movement to develop cardiopulmonary resuscitation. And what that was treatment so that if somebody's heart and lungs stopped, they had a heart attack, their breathing stopped, for any number of reasons, there would be some opportunity in medicine to do these procedures to help to restart their heart and also to get their lungs breathing again. And for many people, the goal was to save patients who would otherwise have died. And for some people, that was very successful. However, about 15 years later, about the mid-1970s, not that long ago, 30-some years ago, we started to see a grassroots efforts of people because some patients decided, well, you know, CPR, cardiopulmonary resuscitation, really doesn't make much sense for me because I have an illness that if my heart and lungs stop, and even if you get it back, I won't live a life that I want to live. That those don't reflect my values, and I wouldn't be able to hug my kids, I wouldn't be able to live independently. In fact, I might be so infirm that that life is not worth living. And so I would prefer not to have that CPR. And so we started to see in the mid-70s the opportunity for people to opt out of cardiopulmonary resuscitation with something called a DNR, which we of course see now on shows like House and on ER. The DNR stands for Do Not Resuscitate, which means we are allowing patients the opportunity not to have that resuscitation. A major case many of your viewers might have recalled was Karen Quinlan in 1976, a young woman at a party who went into a vegetative state and didn't come out. And her family went to the Supreme Court in New Jersey asking for them to allow them to remove her life support, which they ultimately did. And that was sort of the first right to death case of a family and a patient saying, you know, thank you for all this high-tech hospitalized treatment, but it's not what we want. It's not the kind of life Karen would have wanted or we would have wanted for her, or she would have wanted for herself. We then move into the early 80s, and again, people were using cardiopulmonary resuscitation in the hospitals, sometimes to reverse illnesses that people then lived successfully from, but other times seeing people with these chronic diseases we talked about, where people in fact wouldn't necessarily recover quickly, but instead will sort of languish in the ICU or the CCU in the hospital and not really get up and get better. We saw a very famous case called the Nancy Cruzan case in the early 1990s, a young woman in another car accident who again went into a coma and didn't wake up for years. And her family wanted to withdraw life support from her. The case went all the way to the US Supreme Court. To date, it's the only case that went to the US Supreme Court. And the Supreme Court stated something which was very important. And what they said was people have the right to make their own healthcare decisions. Patients, all of us, have the right to turn to our doctor and tell them what kinds of treatments we don't want for ourselves at any time, including cardiopulmonary resuscitation, and including, in fact, nutrition and hydration, artificial ways to keep us eating or drinking. From that very difficult case in 1990 came the law, the Patient Self-Determination Act, which came from the federal government in 1991, which is typical. A difficult case often brings on legislation. Cruzan was the case. The legislation was this Patient Self-Determination Act. And what that act said was that, and it was a federal law passed by the US Congress, that all patients entering any healthcare institution, the Ventura County Medical Center, community hospital, St. John's, a nursing home, any institution in the United States must be offered the opportunity to fill out an advance directive. And that became law for all of us. Again, giving people the right to make their own healthcare decisions. Advance directives really became very prominent in the early 1990s.
I think what we've been talking about too is we're looking for a conversation. And I know when we're in the intensive care unit and it's an unexpected event, we ask the relatives, you know, have they ever expressed their intent if they were ever in such a state? How do you go about doing that, and is there anything new that's come along that enters that conversation?
Well, that's a great question, Chris. I think that advance directives allow us to do two things in California. Number one, it allows us to name what we call a surrogate decision maker. And what that is if I cannot make a decision for myself because I'm in a coma or I'm really sick, then I can name somebody who will speak on my behalf. Now, it could be my spouse, it could be my friend, it could be my brother, it could be my parent, it could be anybody I want it to be. But what you would want from that surrogate decision maker, that person to help you make decisions for you if you can't, is someone who would respect your values, not what they want for you, but what you want for yourself, that they are able to tell the treating team. So it's exactly what you said. First, it's very important for all of your viewers to say, and it's a difficult conversation, we don't like to talk about this. In California, certainly in Southern California, where for many people death is optional, or they think it is, that people live forever, it's difficult to talk about situations where, gee, maybe that's not what I would want for myself. But if you can get past your denial or the difficulty with the conversation, to say, gee, if I was in that bad situation, what would I want done for myself? And then to have that conversation with the person that says, and if I'm not here to state that, I would like you to state that for me. That's one thing an advance directive does. The other thing it does is, frankly, allows you to create treatment preferences. And you can actually write on a form, and I'll show you the forms, what an advance directive lets you say. If I'm in a coma and it appears I'm not likely to recover, please do not do cardiopulmonary resuscitation. Don't do feedings through a tube. Don't stick a tube in my mouth. That's not what I want. That doesn't reflect the values and the goals that I have for the way I want to live my life. That's the kind of conversation you would have with your surrogate, with your doctor, and your healthcare team.